We're a social healing practice. We're influence a client to see things in a different light, to approach the world in a different way, to learn to modify or change our cognitions or how we experience emotion and express emotion. But it's a personal influence. That's the encouraging part, because I think we do have really astounding influence on many people's lives.
But
on the other hand, if we want to improve, we really have to look at how each individual therapist could be more effective.
If you're a practicing psychotherapist or clinical supervisor, odds are good at some point you've asked yourself, how can we make therapy better? How can we improve our skills over time? Well, you've come to the right place. There's a lot of theories and arguments about this topic, but the research might surprise you. Thankfully, over the next hour, we have the great pleasure of sitting in on this very conversation with two of the most prominent psychotherapy researchers alive today. Hi, everyone. My name's Kevin Reardon, Ph.D. candidate at the University of Wisconsin-Madison, and welcome to Season 3 of Making Therapy Better with Bruce Wampold. Dr. Bruce Wampold is Emeritus Professor at the University of Wisconsin-Madison and renowned for his contributions to psychotherapy research. Across his 40-year career, Bruce has trained and supervised psychologists, counselors, and therapists around the world. He's conducted some of the most original and important psychotherapy research to date. And from all these experiences, he developed the contextual model of psychotherapy, which is presented in the book, The Great Psychotherapy Debate, The Evidence for What Makes Psychotherapy Work, co-authored with Zach Immel. Today, Bruce will be interviewed by Dr. Scott Miller. Scott Miller, Ph.D., is the founder of the International Center for Clinical Excellence, an international consortium of clinicians, researchers, and educators, all dedicated to promoting excellence in behavioral health services. Scott has authored numerous books and dozens of scholarly articles. He is a sought-after public speaker, and his work has been hugely influential in the field. In particular, Scott's work has focused on ways to improve psychotherapist training and skills over time, such as through the systematic approach known as deliberate practice, which is the focus of his two most recent books, Better Results and The Field Guide to Better Results. Through the International Center for Clinical Excellence, Scott offers training programs, workshops, and consultations aimed at improving clinical practice and promoting the use of measurement-based care. Today's podcast is brought to you by CarePaths EHR, a practice management and electronic health record system with integrated measurement-based care, telehealth, and HIPAA-compatible AI-assisted progress notes. Research shows that therapists can get better outcomes today through measurement-based care, and with CarePaths, that's never been easier. Head over to carepaths.com now to learn more about how we can help you to make your therapy better. And with that, let's tune in for this very special conversation between Scott and Bruce.
welcome everybody. It's great to see so many people turn up from different places around the world for this interview with someone that is a longtime friend, and I actually consider this opportunity a possible celebration of our nearly, or actually more, I guess I'm embarrassed to say 40-year friendship. It started out when I was a graduate student, and I was taking my first stats course, and this young guy showed up, and I'm not sure if it was his first or second year. I didn't know that at the time. Otherwise, I would have attributed all of my lack of understanding to his inexpert teaching methods rather than my statistical disabilities, really. And that person, of course, you all know as Bruce Wampold. who has, as you heard, contributed so very much to the field. Hey, Bruce, good to see you.
Good to see you, Scott. And it has been a long time. And I think today we're going to continue a conversation we've had maybe, 20, 30 times in the last few years discussing issues about psychotherapy. So, we have advertised this as you're interviewing me, but this is a conversation between us as we discuss important issues in our field. And I think we are at a crucial time for the development of psychotherapy. There's so many things happening technologically, culturally, medically in our field that we have to be on top of this to think about how to, not just to promote psychotherapy, but how to actually make it important for people in their lives.
Mm. And that's something, Bruce, that I noticed from the very outset of working with you, both as a grad student and in a long mentoring relationship. It's evolved into from just mentoring to also consulting and really an amazing friendship, which I deeply appreciate the opportunity to come to your house, taste the magnificent espresso that you make. I'm not going to let you all know where Bruce's address is because you'll go to his house to get some as well. But to maybe start off, Bruce, I just want to ring your bell a little bit, and so that others can, if they don't know, celebrate with me the contributions or some of them that you've made to the field. And I'm going to go all the way back to 1997. I'd finished graduate school. I think by this time you were now in Wisconsin and then moved on from where we met when I was in graduate school. 1997, you publish an article that I'm not overstating it when I say it changed the entire field. It changed how researchers thought of what they were doing. And if you, as those that are listening in, can think back to that particular period of time, there were meta-analyses. The one that comes to mind, I believe, was by Robinson, which had essentially established that CBT was the method, and it was better than all methods. And you did a study together with grad students, which said, wait a minute, our entire way of addressing this question of relative efficacy, is one method better than another, could not be established by the way we were doing research at the time. And you suggested it had to be direct comparisons in the research, one method compared to another method within the same study. And it's hard to just, it's impossible to understate actually the impact of that particular study. Can you just go back to that time and recapture it a bit for us, and then tell us what you're most puzzled by in the years that followed?
Yeah. Well, it's interesting, Scott, because at the time, in my position in Wisconsin, I was actually teaching that CBT was the treatment of choice, more scientific, particularly for anxiety disorders. And the students kind of pushed back because it was kind of an eclectic training that no, we don't want to do CBT, and that kind of irritated me because I thought this was the scientific way to proceed. And I was trained in mathematics and science, so had a reverence, and as one of the motivating factors in that 1997 study. But anyway, I didn't have access to clients to do some research on psychotherapy. So I was actually studying the interpersonal relationships in science laboratories. I spent a year or two studying several famous chemistry labs at the University of Wisconsin, both quantitative research, and I spent a summer as a participant observer in the labs. So the motivation for that study was I was teaching a course on research in psychotherapy. And the book that we used was the Bible, the Handbook of Psychotherapy and Behavior Change. And the assignment to the students was I assigned a chapter to each of the students, and I asked them to go back and read the original research cited in that chapter and report whether the conclusions of the chapters matched the evidence that they were reading.
Hmm.
And time after time, they came back and said, the conclusions really aren't justified by the research. And as a kind of a scientist, that really upset me because if we're going to progress, we have to have reverence for what the research really says. And then, of course, Scott, as you know, my personality is a little uh, uh, against authority telling me what I should believe. So there was a personal part of it. And there was also another personal part, and that is me personally had benefited from my own psychotherapy, which was not cognitive behavioral. And it was more psychodynamic oriented, which I needed because I needed to explore several events in my life, particularly my mother dying when I was very young, that really influenced my adjustment. So anyway, we got busy doing the meta-analysis, and it was exciting because we had read previous claims both for kind of the uniformity of outcomes, the dodo bird effect, as we know from 1936 and saw Rosenzweig, to those who claimed that there was clear evidence that some treatments, particularly CBT, were superior to others. And, in that argument are famous characters, Gene Glass, Hans Eysenck, of course, and it's a fascinating history. But we did want to do this in the most careful way, methodologically. And so we used some pretty sophisticated methods. And it was so absolutely clear, the results. There wasn't one inkling that one treatment was superior to another. Now, we reviewed 300 studies. You could find one or two studies that showed one treatment was uh, uh, more effective than another. But those were the exceptions, not the rule. And the rule was that most outcomes, the preponderance of outcomes, really showed little difference between the treatments. Now, to what I think is the important part of your question, and that is what surprised me by the reaction. Of course, people criticized the study. You didn't do this, you didn't do that, which we responded to and really didn't affect the result. But what surprised me is how little interest there was in how this could be possible. How is it that we have, well, then it was 400 something, and now John Norcross says, I quit counting at 550 because it's an impossible task. How is it that every legitimate treatment that's intended to be therapeutic, given by therapists who believe in the treatment and are skilled therapists, produces about the same outcomes? That's something to really think about. And so little of our field actually says, how could this possibly be that so many different treatments? I mean, you think about the variety of treatments from behavioral, cognitive behavioral, psychodynamic, emotion focus. These are so different,
Hmm.
and yet the outcomes
Hmm.
about the same. That tells us something important.
Hmm.
And so many in the field just kind of so immersed in what they're doing and their treatments that they don't take this view of the larger kind of landscape, which is quite amazing.
Hmm. So this lack of curiosity about the results, and it's not the first time, not only in our field, but in science, Semmelweis's observations were largely rejected at the time. Uh, I, I guess my view of some of this has changed a little bit. Initially, I think I believed, and based on my own experiences, this had to do with being wrapped up in the beliefs of the approach that I was already using and having invested a lot. And in fact, I think that's what Lambert said in his chapter, or maybe it was actually Jerome Frank that's made this point that there's little to be gained from in finding out that the method you've invested all this time, money, and training in is no different than anything else.
Yeah.
But I wonder in part too, Bruce, if it's not because we therapists need to be able to do something. They need a way of working, because I think a toxic interpretation of the common factors is it doesn't matter what you do. You can just do anything and it all works.
Or almost you can do nothing. And I'll tell you some stories about therapists who I think are doing, and we have to explain what nothing means because they're doing something very important. But my work has been interpreted that way as well. Sorry to interrupt.
No. I finished my
Yeah.
thought. So we had to actually translate this into something that people could do. So 1997, it's now nearly 3 decades ago, and have we made progress, I guess, is the next question. Because we're clearly not saying your work is insane, Jerome Frank was insane, Saul Rosenzweig wasn't saying that it didn't matter what you did, you could just do whatever. So have we made progress? Is there more interest now?
Well, let's kind of put off the question of progress just for a minute, because I
Okay.
think you raised that important thing about how my work and other common factor people as well is interpreted. And I'm going to tell a story because that's what we do after we've been 40 years in the field, right? We tell stories. But I was supervising a psychologist in training, and I watched the session live. And then afterwards, we were having the supervision. And this was really before we started the deliberate practice kind of efforts. But I asked him, what was the theme for this session? And he said, he mentioned a few things. And I said, well, if you watch the video of this, you're not going to see that theme apparent. So I wonder if the client was confused about what they're doing because there didn't seem to be any coherent action. And he turned to me and he said, "But you're the advocate for the common factors. I was being empathic, warm, caring. I was exploring different issues." I said, "Yeah, but one of the common factors is this coherent," and Jerome Frank called it coherent myth, which is the explanation for what's going on, and the ritual, a coherent way to address the problem. So Jerome Frank talked about uh, 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 patients' hard work towards their goal and understanding how that work leads to improvement.
Hmm.
And, you know, Jerome Frank and others have argued this is what we do in therapy. We have an explanation for the dysfunction, the distress, and a way to overcome it, which promotes positive change and learning by the client. So there is this interpretation of my work that you can do anything and you can do nothing. So in actual supervision of therapists and supervision of supervisors, this idea about having a cogent rationale and a plan of action, it's flexible, of course, is really important. And many therapists, if you watch their sessions or talk to them, there isn't that deliberate work towards goals. And we know from research in the Alliance that that's really important. Now, on the other side, we also know therapists who are very manual focused and inflexible. This idea that it's session 3, and this is what the manual says I do in session 3. Both of those extremes are detrimental, and there's research to show that. It's the kind of combination of warmth, caring, and understanding with a cogent treatment that both the therapist and the client believe is going to be helpful. So, and yes, we want a therapist who's really believes this treatment is beneficial and who is very persuasive, and I use that term intentionally, very persuasive to induce me to think that this is going to be helpful. And then to use that to help me do things differently in my life, to learn more adaptive responses, more adaptive thinking, more adaptive emotional experience and expression. These are all health promoting things. So,
And
are we going to get to the question of progress?
Well, no, let's hold on that.
Okay.
And I just want to, because I think that the way I experience some of what you're describing is, I guess I would call it a Goldilocks moment, that you find exactly the right amount of structure, or you find the structure and you balance that with the comfort of the mattress that we're all going to be sitting on in a minute. And that sounds good in theory at a 30,000 foot level, but therapists live in a day-to-day practical level. And oftentimes my experience of the common factors, say in contrast to my own therapy experiences or the first 5 years of my career when I was working with Steve DeShazer and Insoo Berg, was that they could tell you exactly what to do at this moment and the next. And so I get it. That we're suggesting something a bit more flexible, finding the right sweet spot.
Well, I think there's convincing research, and from my experience, that the really demonstrably effective, because we're both very invested in measuring outcomes as a tool to improve clinical work. But those therapists who really do produce outstanding results are, if you watch them and you understand what they're doing, flexible. And I often refer to a tape I saw you doing therapy where you completely changed the explanation almost instantaneously based on, which tape I'm thinking of probably.
Yeah, I do.
But it's so important to understand how what we're doing as therapists is being received. I mean, you have to watch really carefully to look at the acceptance and the engagement. Clients, by and large, are not going to tell you you're a rotten therapist.
Yeah.
Okay. And those that do are probably oppositional. But You have to look at the subtle engagement, clues,
Mm.
cues to engagement, and to flex that therapy. And that's a pretty sophisticated skill. And we should talk about how to do that with deliberate practice, because
Perfect.
that's a higher level skill. And, I think in the deliberate practice world, we're still kind of teaching the most basic skills and the higher level ones. And, reading Anders Ericsson and others work on expertise, learning the higher level skills, kind of the mental map and hypothesis questions are more difficult to teach.
Mm. And there does seem to be an urgency to do this. And maybe this is what you were hinting at in the very first moments of our conversation. So let me give you some numbers here. We have 175 psychotherapy journals,
Yeah.
160,000 plus articles that have been published. We're talking about scholarly articles here, not necessarily articles that might appear in popular magazines about psychotherapy. 28,500 peer-reviewed studies. 78% of those studies focus on the top 5 brands: CBT, psychodynamic therapy, family systems, behavioral, and then the rest to just make up a small number. 1,000 brands are what I could find. And yet, I don't see any evidence that the outcomes of psychological care have improved. And when I first made this statement in 2017 at the Evolution Conference, it caused quite a bit of controversy. But now we have other people saying, if we look at Smith and Glass in 76, Prochaska and Norcross do an article on, and Weiss do an article, I think it was, in American Psychology, the kids' treatments, it's essentially the same. The overall effect sizes haven't changed. And yet, if you look at the catalog of continuing education courses that therapists can avail themselves of, it's of the latest brand of treatment for this particular population in this particular context. And of course, if you attend the course for enough time, you get a certificate that says you're skilled in it. So what does this mean? Where do we go? Because clearly the demand for mental health services is way up following this black swan event of the pandemic and the convergence of a host of other cultural changes. The need is there, and yet we're training people exactly or mostly the same way we did 20, 30, 40 years ago.
I'm smiling, Scott, because the answer to this question is going to take us about 3 hours.
All right, everybody, hang on and clear your schedules.
Yeah, you've raised so many important points. So the first one is psychotherapy getting better? And it's an interesting idea, and you cited in your publications and books about well, if you look at times for the 100-meter dash, they have decreased dramatically over the year. People are getting better at running, and it's true of just about every sport.
Yeah.
And the evidence, as you cite in psychotherapy, we're really not on average improving over time. And you didn't cite this, but therapists don't seem to improve over the course of their career.
Yeah.
And you can take that and be very discouraged. Okay. So here's my answer to the, are we improving over time?
And can I stop you there and just ask a follow-up?
Yeah.
I just have a sense you're not discouraged.
Well, I'm a complex person, so it depends the day. There's, and I'll talk about this. There's parts of it that it is discouraging, and there's parts of it that I think we misinterpret. Okay. Look, and I talk about this, we're a social healing practice. We're influenced a client to see things in a different light, to approach the world in a different way, to learn to modify or change our cognitions or how we experience emotion and express emotion. But it's a personal influence, and we're kind of at an asymptote. We're not really going to be able to refine psychotherapy in a way where there's a quantum leap, where in 3 years the outcomes will be twice as good as they are now. You see those quantum leaps in some areas of medicine. They're kind of overestimated sometimes, and there's good evidence for that. But we're not going to see that in psychotherapy. Nevertheless, for most disorders, psychotherapy is as effective as medications. And here we've had years of biological psychiatry working to isolate processes within the brain that can be modified by different drugs or procedures. And yet we're as effective as medications for anxiety disorders, depression, other disorders. So, and I should mention, with fewer side effects, of course. We don't alter people's libido or decrease it. We probably increase it, right? Modification, sleep, energy, and so forth. So, and we have less recidivism. The relapse rate after psychotherapy is terminated is much better than the relapse rate when antidepressants are discontinued. So we're doing really damn well.
Yeah.
Okay. That's the encouraging part, because I
Yeah.
think we do have really astounding influence on many people's lives.
And can I just
Yeah.
add that when we look at real world data, monitoring the outcomes of clinicians, I see that very thing. I see the impact that therapists are having in the lives of their client. If we just look at the average effectiveness of clinicians, they're on par with the results obtained in randomized controlled trials, and often working with clients that are much more messy, frankly, than those often in the controlled trials that are published in research journals. But apologize for interrupting.
Yeah. No, that's true.
But
on the other hand, if we want to improve, we really have to look at how each individual therapist could be more effective. And you also know from looking at that data, and we both looked at lots of data, there are many therapists whose outcomes are, I want to say this carefully, relatively poor. Okay. And supervising therapist, sometimes I get discouraged by the quality of the therapy that I am witnessing. I just want to say, you can't do this. You really need to focus on this. And so,
and can I ask you, Bruce, is it your sense that when you watch this work being done that is of poor quality in terms of its persuasiveness or engagement of the client, is the concern that it is of poor quality, or that the therapist seems unaware of it, or that the therapist actually thinks it's good work, or that they can explain it even though it doesn't work? What is the thing that emerges from that?
Well, yeah, that's a great question. I think, well, and we've discussed this, it's a very difficult learning environment for a therapist. Okay. The feedback we get, even if you use some kind of outcome measure, it doesn't really give you a fine-grained feedback about what you could do differently in therapy to improve. And we'll get into maybe deliberate practice and why it's necessary. But the part I was going to lead up to is that the way we train therapists hasn't really changed in 100 years.
Mm.
We teach them some basic skills in programs that teach particular models. You'll learn about particular models. And then we turn them loose on patients, right? And we give them feedback, which generally is very general. I've watched supervision tapes as well. And most supervision is focused on the patient. What's the diagnosis? What's the difficulty? How do we interpret their resistance to therapy? Rather than on what the therapist could do differently and how to actually learn to do it differently. Because you can give specific feedback in supervision, but the interaction which led to the therapeutic error only is going to occur infrequently. So a month later, something similar happens, and they do exactly the same thing they were doing before. And they go, duh, I did it. Because they haven't practiced how to do this. I mean, this is our focus on deliberate practice. It takes work to learn to respond in difficult moments in psychotherapy in different ways.
So we've got these errors of responsiveness that I like to label random errors. The environment is complex, we miss an opportunity, but it may not be part of a recurring pattern or a non-random error, something that we repeat over and over again, given certain contextual pressures, that has a deleterious impact on client engagement or outcome. And I hope this doesn't seem like too far of a reach here, but in the study, the now 2 studies that we have, of course, the original Goldberg study and then the follow-up done in Germany, showing that therapists do not improve with time and experience. In both instances, there were exceptions to the general rule. There were therapists who defied the trend not to improve or to deteriorate with time and attention. And you seem to be hinting at those people that they might have something they could teach us.
Well, let's go back to something you said earlier about the number of studies, how many journals there are, how much research there is in psychotherapy. So much of it is devoted, and NIMH funds it to investigate treatments. Do you remember when I submitted a grant to NIMH? You were one of the trainers in one of the conditions. We wanted to study therapists and how to help therapists improve. And NIMH predictably said, well, we don't fund research like that. You have to have a manual for treatment and you have to study particular therapies.
Yeah.
And there's so much we could learn, Scott, from kind of redoing the focus of our research onto therapists and how therapists can improve.
Are you in therapy and not sure if it's working? The Making Therapy Better app lets you easily measure how you're doing over time. Mental health research shows that tracking your progress and discussing it with your therapist leads to better results. So download the Making Therapy Better app today. It's absolutely free and takes less than 5 minutes per week. Results are easily shared with your therapist so you can both be sure that you're on the right track. It's time to make your therapy better.
So I make, again, two bold claims and have you react. And I'm watching as people are asking questions in the chat. Great, keep that up. And Barrett will help us when we get to that section. But first, let me make my first bold statement. Number one, personally, I do not believe we need another funded randomized trial of CBT for a very, very long time. People make their careers off publishing this stuff. The number of times each of these studies is cited by somebody else is very low. Its translation to something practical that clinicians can do to improve their outcome is near zero, I would say.
Well, Scott, if you ask people who are clinical trialists in psychotherapy, what have we learned from the clinical trials other than psychotherapy works and that there aren't differences among treatments, which, as you say, we knew both of those things in 1997. They can't answer.
Yeah.
They really can't tell you.
Yeah.
So absolutely right. The money and the talent that is spent doing clinical trials has not led to any actionable thing a therapist could actually do other than I should do this manual, right?
Yeah.
It's well, our focus, I agree, needs to change. Put it that way.
Yeah, and as you say, to be more focused on the therapist. And there are some people that I think have put into practical research that perspective that sort of emerges out of the work on relationship and the interaction between client and therapist. We can talk about Anderson in a moment. Our own group just published a study that made its way through really, I'm embarrassed to say, a 7-year publication journey, trying to deal with the peer reviewers who had all sorts of issues with the nature of the design. So there are people doing that, and I want to talk about it. The allure, or just the tradition of, we're going to do a study on acceptance and commitment therapy, then we're going to do a study on CBT, then we're going to compare that to interpersonal psychotherapy. This is such a powerful thing, and it's reflected in the training that therapists get, both pre and postgraduate. Our team found this such a challenge, as you know, that we replicated the Consumer Reports study about 6 years ago now, 7, and asked how people experience therapists and psychics and tarot card readers. And you're not going to be surprised to find that, number one, people really liked seeing a psychic, that their interventions were, in contrast to, I think, what you might tend to believe, or might believe based on the media, were relatively brief. But most important for me, where they really connected were on two things. Number one, giving the clients what they came for. And number two, the clients feeling like they were really heard and listened to and appreciated. It wasn't that they told them whatever they wanted to hear. They often gave them advice or counsel or predicted things that were actually ego-dystonic or unpleasant. So I know that we do have to change those things.
Well, Scott, let's unpack the psychic part of it and really delve into this, because I think it's a controversial conjecture, to say the least. But we can learn something, and this is Jerome Frank's work, from indigenous healers, from medical practices. Yeah, the new edition.
And by the way, a new edition coming out, or is it already out, Bruce?
Well, March 18th.
So Bruce is not going to say this, so I'll just tell everybody. Bruce has worked together with Jerome Frank's daughter, who was on the second and third editions, Julia, And he is now one of the authors of Persuasion and Healing. If you haven't read this book at some point during your career, it's truly a must read.
Yeah, it is. It is. And well, we could spend time on that. But what are the dimensions of help in social healing? One is this being heard. You talked about being heard. That's the warmth, caring, understanding part of psychotherapy. Okay. So yeah, that's absolutely necessary. And again, that involves skills that really need to be practiced deliberately to be optimally effective.
Hmm.
You know, oh, I'm a warm and caring person. I just go into the session and it's just going to come out naturally. No, you actually have to practice this. So that's the one dimension. The second dimension is some work towards the goals, the problem. So when you go to a psychic, you go to a therapist, you go to the doctor, you want some plan for how you're going to overcome this. Now, the psychic uses a little bit of magic in a way to induce somebody to either look at the world differently, do something differently. And if they're good, they're going to elicit something that's healthy for that person. So those dimensions are the same dimensions in medicine. And people talk about, Leah Crum talks about, you want your doctor to get me, understand me, and be warm and caring, and get it, the problem, and how to overcome it. And that's just common sense. When
Yeah.
you that's what you want in a healer, is somebody warm, caring, understanding, knows you, takes time to understand not just your disorder, but you as a person, and then has a plan to overcome that difficulty.
And I've mentioned him before, but one of the people who I believe, and his team and now others, that's been looking at how to translate some of these maybe poorly defined or fuzzy concepts like warmth is Tim Anderson. And can you talk just a little bit about him? Because again, I'm surprised when I'm out and about and talking about him, very few know about his work.
Well, I say this often. Tim Anderson's study on the facilitative interpersonal skills is probably the most innovative and important study in psychotherapy. Because what he did is, he said, and this is true, so much, if you watch videotapes, so much of what the therapist does is actually accounted for by the client.
Yeah.
We know interpersonally aggressive clients will elicit therapist responses which don't look very good. Okay. James Boswell did a study on this where he showed it quite sophisticatedly. They're going to appear less competent. So Tim said, I need therapists to see exactly the same client. Then I have a standard stimulus and I can see. So Tim had a collection of therapists where they knew what the outcomes were. They knew who was the most effective therapist and who were the less effective therapists. And he said, I want to have them see a standard client, which of course you can't do. So what he did is he had these 8 videotapes of difficult clients picked from around the interpersonal circles. So there was one client from every octant. These are difficult vignettes, the patient's doing something which is very complicated, either being kind of interpersonally aggressive or disengaged and passive, let's say.
Yeah,
Then
that
he
range.
had the therapist respond to it. Okay, just videotape your response. And Tim then coded along this, are there 7 or 8 different interpersonal skills? The facilitative interpersonal skills: warmth, caring, alliance repair, persuasiveness. I'm missing a few.
Yeah.
And then he scored the therapists and correlated those scores with their actual outcomes. And there was a relatively robust correlation between those basic skills and the outcomes. First study ever that measured anything about a therapist outside of therapy, the predicted outcomes.
And would you say that again, Bruce? Because that's got to sink in. The first study ever. Okay, we have, what did I say? 28,500 RCTs, 160,000 articles, 175 research journals, and it was, say it again?
The first study that had ever assessed anything about a therapist outside of therapy, the predicted outcomes. Now, Scott, again, has the field really understood how important this is, and say, well, if these are the skills that characterize effective therapists, we need to deliberately teach and practice those skills. But in our training programs and in supervision, we're not really focused on those particular skills. So, for example, I forgot 2 of the most important facilitative interpersonal skills are recognition of client affect. Okay. Do you understand the affect that's not just being expressed? Because you have an angry client, yeah, that's anger, but often it's a very subtle experience, or even maybe a unconscious or conscious covering up of an affect. How well can you recognize that? So that's the decoding affect.
Hmm.
And how well can you modulate your own affective reaction? Those are 2 very difficult skills.
Yeah.
And by the way, Scott, if I had to pick in supervision skills that often are need improvement, I almost said not existed, but they need improvement, I want to say it in a positive way, is recognizing and responding to affect. Okay, I'll give you an example. Here's an example. An experienced therapist was seeing a client who had an argument with her husband. The husband left, slammed the door. And she comes into therapy and said, I've never, ever kind of disagree with my husband because I know he's volatile, but I finally just had it. And I just had to say something, even though I was scared to death he was going to leave. Okay. And then I did it, and he did leave. Do you know what this experienced therapist said? How long have you been married? Avoiding difficult affect in one way or another. That's an extreme example. Can't, and that takes practice. It's not just simply, oh, what was it in your history that makes you avoid affect of this? No, this is a difficult thing to respond. This is a woman who clearly was having fear that this guy was not coming back. Her husband was not coming back.
And being able to identify both the explicit emotion, the one that's obvious, the fear, and then maybe the implicit emotion as well. that could be anger or resentment. That so this is essentially the core of the study that Daryl Chow and the group that I work with just published, that had this torturous journey through the publication process, aimed at first assessing therapists' overall empathic abilities, and then identifying empathic weaknesses using standardized stimulus drawn from real clinical context, and then developing a specific feedback regimen to teach them the skill that seemed to be missing. And as you know, we saw a near linear improvement over the course of the study, and then it leveled off. So it is possible to train these. The assumption
It's not just possible, Scott. It's an imperative. Okay? These are particular skills that Tim Anderson, and I think there's some others as well, and we could debate whether these are the essential skills or there's some other, or they're higher order skills. But these are skills that can be practiced and improved.
So, and maybe this is too big because we're at the micro level now, but if I step back out to the macro level, sometimes at the workshops that I teach, I'll say, when was the last time you saw a workshop advertised for continuing education credit on improving your relationship skills? And I might get one person, and then I accuse them of lying, because it just doesn't happen. When was the last time you saw an offering for some specific diagnosis or treatment approach? All the hands go up. And the assumption is, I get a little training in the new trauma thing, get a little training in the new narrative thing, and then somehow my outcomes will improve. All of which, by the way the learning environment is actually leads therapists to think they're improving, when in fact they're not. Continuing education attendance actually leads to increased confidence, which is the antithesis of what we need for therapists to be willing to explore. So if I go back out to the macro level, Bruce, where does the impetus lie for changing some of this? Is it at the academic level, the university level, changing the EPPP so that people have a different what's demanded of them? Where does the impetus lie?
Scott,
another 3 hours?
Oh, no. Well, it's not just another 3 hours, because you and I and others have been trying to do this, trying to make inroads to promote a different way of training, supervision, becoming a more skilled therapist. And we have made inroads, you particularly through your center. But relatively, if you think about the population of therapists, we're not reaching the majority of this. I mean, how many training programs even measure outcomes in the training clinics? And that's the most basic level of knowing if you're doing an effective job, you're benefiting patients, let alone in the training to actually practicing particular skills. And you brought up the case of empathy as something that takes practice to do. Even if you are an empathic person and you resonate to the lived experience of this client, being able to express that. Scott, we gave, and I know Nicholas is on the call here, in Sweden at one of the conferences, this idea about responding to emotion. And I talked about responding not just to the explicit affect, but to the inferred affect. And I got criticized by the audience because that is a therapist kind of superior attitude towards knowing something that the patient hasn't expressed. And that's creates this hierarchy. The therapist as expert and the patient as unaware. But I went back and watched Carl Rogers talking about empathy, and he talked exactly about implicit empathy and the necessity of the therapist to infer about the complicated affect and conflicts. And it's quite amazing to watch Carl Rogers talk about this.
Mm, mm. So,
So one other story, because I
yeah.
can't resist. How are we doing for time? We just got to move. I was fortunate enough to be at a kind of workshop at a hospital with Daniel Kahneman, who's one of the few psychologists to win the Nobel Prize. And somebody in the audience asked him a question about clinical judgments, trying to make the point that clinical judgment was superior to actuarial judgment. And they got in a little bit of an argument about this. And finally, Kahneman says to him, "How confident are you in your response?" And he says, "I'm very confident." And Kahneman said, well, I won the Nobel Prize on the basis of showing that confidence and actual effectiveness are inversely related. So that's exactly what you were talking about. That, yeah, as we gain experience, we increase our confidence about what we're doing, even though the outcomes don't improve. And what we're really good at as experienced therapists is talking about cases. I love listening to wise therapists talking about cases. But that's not what makes the difference in the outcomes. Is not our ability to do these complex analyses of what's going on. Now, I don't want to give the false impression. Case conceptualization is an important skill, but it's got to get translated into actions in the treatment. So that's one of the higher level skills.
And I know we're running right up against the time, but I just wanted to give a shout out because I know you interviewed as part of your Making Therapy podcast a number of interesting people that I really like. Nancy McWilliams, for example, is somebody that I really like. Ed Hagen's interview is fantastic. But you also interviewed Helene Nielsen-Lee, a Norwegian psychologist, about humility. And I just wanted to give a shout out for that particular interview because it fits with one of the findings from our study using the essential framework that Tim Anderson came up with. And that was that therapists rated their confidence level about their empathic responses at the beginning of the trials. And over time, with feedback, their confidence levels slowly degraded. But their actual measured empathic response improved. It was as though therapists saw more nuance and difficulty and had to make some different choices rather than just the standard automatic response that came in the case that you mentioned, how long have you been married response, which I'm sure the therapist could, if asked, defend to the ends of the earth why that was an appropriate question at that moment. But getting the feedback specific to their responses tended to undermine that. And I mean that in a positive way, that suddenly they saw I could respond in multiple different ways.
Well, Scott, it's uncomfortable for someone to tell us that what we're doing has much need for improvement. And we know this from everyday life. A coach in some kind of athletic activity who comes in and tells you you're basically doing things that retard or make your performance less than it could be. We don't want to hear that. We want to hear you're doing great.
Yeah.
But that's really necessary to improve. So one of the things Helena found is that those therapists who had what she called professional self-doubt had better outcomes. But there's a missing link there. It's not just the professional self-doubt. It's the fact that that doubt motivates you to improve.
Yeah.
Then you have to actually do the work to improve.
Yeah.
And so this isn't some magical thing that if I'm a reflective practitioner, I'm going to get better. It takes work to do.
Yeah. Hey, Bruce, I'm looking at the time, and we are right up at the end of the amount that we budgeted for this particular interview. I want to thank you. I want to thank CarePaths for making this possible today, and let people know, and I see that Barrett has been saying this as well, that this interview will be uploaded to the Making Therapy Better podcast site. Will also be on my site in probably 7 to 10 days or so.
Well, Scott, as usual, we could continue for another hour or two.
I
And
know.
I want to reiterate what you said at the beginning. Our friendship, but also our working relationship, because over the years, we both pushed each other to understand and things better and to be more effective in what we do. And so this relationship has been absolutely critical in my development and what I've done in my career. So you began by thanking me. I'm going to thank you because it's been absolutely remarkable, ongoing for so many years.
Yeah, that's the coolest part. It has been going for so many years. Thanks, Bruce.
Yeah.
Thanks, Barrett. Thanks, everybody, for joining us.
Okay, that concludes this very special episode of the Making Therapy Better podcast with Bruce Wampold. We hope you'll stay tuned for the rest of season 3. We have a lot of exciting guests coming up and can't wait to share that with you every other Wednesday morning on wherever you get your podcasts. And as always, today's podcast was brought to you by CarePaths EHR. Are you a clinical supervisor or do you run a training clinic? CarePaths is a comprehensive electronic health record system built with you in mind. Research shows that therapists get better outcomes and improve more over the course of their careers when they regularly measure their clients' treatment progress and experiences in therapy and then discuss those measures collaboratively. Along with a host of other features, CarePaths makes it easy for therapists to integrate measurement-based care into their practice with just a few clicks. Head over to carepaths.com now to learn more about our EHR system designed with training clinics in mind, and join us on the path toward making therapy better. Thanks so much for joining us. Take care of each other. Take care of yourselves. We hope to see you next time.